St. Paul Hospital, Minil. So this weekly session, which is intended for fellows to support clinical care training in those two hospitals at St. Paul Hospital, Millennium Medical College, and Kwalibu Teaching Hospital in Ghana, Accra, and mainly supported by the Johns Hopkins University in the Department of Emergency Medicine. Today, our presentation will be on management of acute CNS infection in immunocompetent patients. It is a wide topic, but we have experienced presenter. Her name is Bhava Seth. I think she will correct it. Bhavna Seth. She is a medical doctor working currently at University of Petersburg. She is trained in internal medicine. She has 10 years of experience in emergency, in ICU and pulmonology medicine. So she is well experienced in this topic. Thank you very much for joining us. It will be a good session and very helpful for our fellows. The floor is yours, Dr. Seth. Thank you very much.
Thank you. Thank you so much, Dr. Sultan, for the introduction. Welcome, everyone. I'm sure you're all excited with all the knowledge you've gained in this series, and I'm hoping to tie together some of the older sessions you've had into this. So we're going to talk about infections in the brain. So neurological infections often are meningitis, encephalitis, and abscesses are the most common types. And so today we hope to cover how to approach these. It's a very broad space and covers, you can learn all of infectious disease and all of neurology through this talk. So I'm very excited for us today. And we'll learn basic diagnostic and therapeutic approaches. And then especially since we are focused in the ICU space, what to monitor for, what to look out for in your patients who you are worried have these infections. All right, so this is, as I mentioned, a very broad topic, so I'm going to cover some broad touch points, but give you the key highlights that are diagnostic imperatives and therapeutic imperatives that should not be missed. And overall, this should be a fascinating journey. So first things first, acute meningitis is a medical emergency. Just like sepsis or a myocardial infarction or a PE, these are diagnostic imperatives that you do not want to miss. If there is any suspicion for acute meningitis, time is life, and early empiric antibiotics saves lives. So definitely intervene as soon as possible. And like a lot of things in critical care, it's also challenging. There's a lot of uncertainty, so you have to triage, resuscitate, monitor, and do all of this simultaneously. So you're empirically treating, but waiting on diagnostic information, but also monitoring for patients' clinical evolution. And just to highlight the point of time, this was a study done, a Danish study with a population of about 194 patients, where they looked at acute community-acquired bacterial meningitis. And on the x-axis, we see time in hours. And as you see, as time increased, even beyond 6 hours, in-hospital mortality increased. And one can imagine if patients often present later in their course, then these graphs can be a lot higher over time as well. So when they present and you worry, it's good to start antibiotics soon. In terms of the global burden of meningitis, this is a global map, and as we can see, this is very important for us, because in the African context, in red are the higher prevalence, and these are all estimates, and the truer numbers may be more stark in ways. What is also curious about the epidemiology is that there's a meningitic belt that goes from Senegal to Ethiopia and covering touches of Ghana as well. And most commonly, this is Neisseria meningitidis. And there's a lot of uncertainty of why this sort of prevalence is seen. There's some hypothesis of the dry winds and climate in addition to the population. So this is an interesting element in terms of the prevalence, but also helpful in terms of your empiric treatment. So a general approach is mentioned, these are the common infections, and it can affect any element of the neural axis. We're focused on the central nervous system, but peripheral nervous systems can also be, and your spinal cord can also be affected by infections and should be considered in your differential. However, patients with these infections may present with any other neurological symptoms. So they may have encephalopathy or be confused and have delirium. They may present with seizures, or they may have focal neurological deficits. And as you know, these themselves have broad differentials amongst them. And so oftentimes it's very challenging to tease out infectious versus non-infectious syndromes, and maintaining a broad differential at the outset, including, I often use a mnemonic IIMM, which is infectious, inflammatory, metabolic, and malignant, keeping those differentials in mind as you are empirically stabilizing and developing a diagnostic and therapeutic plan for your patients is helpful. And as mentioned, time is life, and so empiric treatment is necessary. In terms of how this occurs, so it can be hematogenously spread or neuronal directly through the nerve roots, especially in the case of rabies. But also it can be transmitted from organ systems nearby. And this is a picture of the orbital plate being infiltrated by a sinus infection. I recently had a patient who had malignant otitis externa, which caused meningitis, and our patient actually then developed the need for, almost developed herniation and needed an external ventricular drain placed emergently. Trauma creates a direct route for CSF to connect with the outside environment, and this is a high risk for infection. Any patients who have devices such as ventriculoperitoneal shunts or prior surgeries are also at very high risk. And then the other interesting ones which have a slightly different presentation than the classic meningitis or encephalitis is the neurotoxin-related ones. And here you may get a clear exposure history. In terms of the presentation, I'm sure you're all well aware of the syndromic approach, but overall thinking of what part of the body is involved. In the case of meningitis, it's the outer lining of the brain, and so the brain tissue itself is not affected. So one can imagine that our cognitive faculties are not impacted as much. So if you do start to see altered mental status, often even very subtle things like psychiatric symptoms or just feeling fuzzy, all of these things can be signs of encephalitis or eventual cerebritis from the meningitis or encephalitis directly itself. And then brain abscesses often have a focal neurological deficit depending on where they're located. However, what one should also be aware of, today we are focused on immunocompetent patients. However, immunocompromised patients have a much wider differential and often have much subtler features, which may delay or cause a misdiagnosis. But like a lot of things in our approach to infections and, for instance, sepsis, the main key is to find where's the source of the infection and what type of an infection is it. And so if you see stigmata of infective endocarditis on your exam, then treatment should be targeted towards that. If you see other signs of organ dysfunction, which may be suggestive of malaria, one can focus their treatments towards that. So just to help us learn through today, I'll be walking us through a case throughout the talk today. And so we have a 38-year-old gentleman who presents to your emergency department with a new onset seizure. It resolved spontaneously by the time you assessed him, but he was endorsing a headache, had some photophobia, and a recent fever. His vital signs were overall stable except for a fever. And his exam was also quite unremarkable. There was no papilloedema, neurological assessment was non-focal, and he was speaking in full sentences, so protecting his airway. And in terms of their initial diagnostic evaluation, he was not immunocompromised, had no organ dysfunction, and no prior infections or exposures. So overall, some highlights of fever, seizure, and a headache with photophobia. So overall, while this may be many other differentials, one diagnostic imperative, as we mentioned, should be meningitis or encephalitis. And this is the JAMA series is a great series on the rational clinical assessment and what features are most sensitive and specific. And so in his case, having a fever is a very high risk, but that coupled with other factors increases your pre-test probability that this is meningitis. Unfortunately, a lot of our physical exam findings don't have the best diagnostic characteristics, but them combined in constellation are helpful. And a new physical exam finding that has become more popular recently is called the JOLT acceleration test, which basically you have your patient sort of turn their head back and forth very fast, and you ask them if they have neck pain and neck stiffness. But as mentioned, there are many, many infections and interesting elements out in the world, both infective inflammatory conditions, but also non-infective inflammatory conditions. And so maintaining this broad differential and targeting your history and exam and treatment towards all of these will be helpful. So we today will focus on acute infections. Acute infections tend to mostly be bacterial, but can be viral. And then, as mentioned, related to other triggers like trauma, surgery, and prior infections. And in immunocompromised hosts like those with HIV, the differential can be very varied as well. Fungal chronic infections tend to be more mycobacterial, which you may see a lot, though they may often present in the acute form if especially they have a new stroke or a new complication related to their underlying chronic meningitis. So that is also important to be aware of. And each of these can have superimposed complications that can land patients in your ICUs and make them more acute. So in terms of the treatment, this is also geared towards our epidemiology. And so our patient, who is a 38-year-old male, would probably fall in this second to last bucket, where Streptococcus pneumoniae is the most common. And so our treatment should cover that, but also Neisseria is fairly common. This changes over one's life course. However, this data comes from a US-based population, so there's a possibility that it may vary in different contexts, but a helpful framework for our initial empiric coverage of antibiotics when we don't have a bacterial diagnosis. So other things in history that can lead you in different directions and different differentials are specific zoonoses. So exposures to cats can lead to toxoplasma and very specific lesions on your imaging. Different sheep and dog and other exposures leads to echinococcus, which can affect many other organs, very rarely the brain, but they have been case reports, and then neurocysticercosis, of course. Food exposures, like we discussed earlier, and then swimming has very specific exposures as well, Naegleria being a very fatal diagnosis, unfortunately. And then on exam, you may often see subtle or overt clues, which can help lead you in one direction or another. Skin manifestations, so doing a full assessment for your patient. So the picture on the left is a patient with Neisseria meningitidis and the classic purpuric rash. The patient on the right has a dermatomal rash related to herpes and BCV. And then, like we shared, infective endocarditis, other sources of an infection. And then there are many infections that have ocular manifestations, oftentimes in immunocompromised patients. However, syphilis can lead to this pupillary finding as well. Then, in terms of our diagnostic evaluation, so the tools we mostly have are our exam, our tests, our blood tests, especially cultures. In fact, for bacterial meningitis, 70% of patients may have a positive blood culture, and that's very helpful, especially if you have challenges obtaining a lumbar puncture. Lumbar punctures are indeed most definitive, but have their own inherent risks and concerns. And then imaging in terms of CTs, MRIs, and EEGs can help with especially looking at the underlying differential, but also any superimposed complications. So one question we often face in practice is it safe to perform an LP without a head CT? The concern being that if a patient has a lot of inflammation, you can have a raised intracranial pressure, and doing an LP can lead to sudden decompression and herniation. While this has been a theoretical concern in practice, we often don't wait on imaging if it is logistically challenging. However, there are a few patients where they may be more high risk, where you would want to, especially if their exam is concerning, but also in general, be cautious. Are patients who are elderly, immunocompromised, have seizures, and any focal deficits. So in these patients, you definitely want to try to get imaging before performing an LP to minimize complications. And once you are able to get an LP, then this is a helpful framework to just know what are some of the most sensitive tests that exist currently and for different entities. So if your patient, depending on the tests that come back, you feel may have a viral picture because of lymphocytic infiltrates and other elements, oftentimes PCRs are great and actually quite time efficient to help lead you in a certain direction. Most of the treatable viruses are herpes, so if you're also not able to send it, it's helpful to empirically start your patients on acyclovir while you're waiting on the diagnostic tests. In terms of bacterial entities, culture is invaluable, especially we live in a time now, both for TB and other other general bacteria with a lot of drug resistance. And so in addition to the gram stains, having a culture to help guide your eventual management after your empiric treatment is invaluable. There are some newer diagnostics, which I'll talk about later, of multiplex PCRs, where a wide array of many of these infections are tested all in once, which are great. However, the sensitivity and specificity of those is not as powerful as some of these most sensitive tests. So for instance, in those tests, say you had a patient you were worried about cryptococcus, it's possible that they may be negative on those tests, but their cryptococcal antigen test is positive. So it's important to understand the diagnostic characteristics of the tests you're interpreting. So back to our case. So you assessed him, you were worried for meningitis. However, you're in a busy emergency department and you don't have time to do that LP that you were planning to do. You are running a code, you're admitting a few other people. And so, but we talked earlier, time is life and we want to start antibiotics. However, you're worried if you start antibiotics, would it affect your test results and then make your eventual treatment difficult? So this is also a common question we face. And what is the diagnostic change or yield after antibiotics are initiated? And so overall, the principle is that you should start antibiotics and not delay antibiotics for the LP. As mentioned, blood cultures obtained before the LP can be very diagnostically helpful, but also for a few hours, if it takes a few hours for the antibiotics to go into the CSF stream, if you're able to do it within that time frame, you may still get a good yield. But if not, the cellular and biomolecular changes last for a couple of days. So you may still be able to get clues. Is it at least viral versus bacterial versus another entity, even if you've started antibiotics? So don't wait on the LP and initiate antibiotics as soon as possible. And this is a common framework, which I'm sure many of you have seen. What I will highlight is that for the first row of bacterial entities, the glucose to ratio in the CSF versus blood, if that's less than about 40%, that has a very high likelihood ratio that it is a bacterial entity. And the reverse is true for viral entities. So that's one other test you can use to differentiate bacterial versus viral. Interestingly, fungal entities can also have eosinophils in addition to parasitic entities. So that's another differential to consider when you're interpreting some of these test results. And then oftentimes, and we'll touch on this later, even after you've done a thorough infectious workup, if your patients are not improving, but fall into this sort of latter bucket, it's important to consider some of these non-infectious etiologies as the diagnosis, because that can affect your treatment and hopefully improve your patient's outcome. In terms of further diagnostics, imaging, while it may not reveal a lot if it is meningitis, that exclusion is also very valuable. However, for many of the infections that we have touched upon and that exist, there can be findings on imaging. This is a case of a patient who has tuberculomas in his brain that led to seizures. And this was a helpful framework I found of the 4 H's. So oftentimes it's hard to interpret head CTs and imaging. And so looking for any type of hypo or hyperdensity, and especially in our patients with meningitis, with a high risk of increased intracranial pressure, looking for hydrocephalus or any midline shift or signs of raised intracranial pressure or herniation are important. This is a patient who is 50 years old and had presented with a seizure. I see a few people on the call. I don't know if anyone wants to sort of unmute themselves and provide any differential or considerations based on this. Well, this is probably a better picture. So this is neurocysticercosis. And the point I wanted to highlight with this is that neurocysticercosis can exist in the brain, and but depending on the life cycle of the parasite, you may or may not see the classic sort of dot with the cystic space around it. And so that is a helpful differential to consider. Other imaging findings, so not to belabor this too much, but this reference below has a lovely table of certain common patterns that have been seen in certain infections. It doesn't have the best test characteristics, however, can provide you some lead and direction. So depending on the MRI patterns, you can have these varied differentials, and ring enhancing lesions, of course, have a clear differential as well. This is a patient with a very classic finding. So this is HSV encephalitis, which commonly affects the temporal lobe and can cause this sort of a finding. This is a patient who had a brain abscess from a bacterial lesion. And as you can see, these are quite walled off. So patients may not have much in terms of symptoms aside from the focal neurological deficit. And this patient actually needed a biopsy to be able to get diagnostic yield. And then this is a curious case of a patient with schistosomiasis, which has this very beautiful arborized, which is like tree-like pattern within the brain, unfortunately. So we've covered a lot, and the diagnostic and therapeutic elements, as mentioned, are constantly working in parallel. So, and even within the diagnostic frameworks, we are reiterating based on your patient's response, whether they are improving or not, and expanding your differential if not. So the primary treatment for the neuroinfection is really determined on what infection you find. And that goes back to your differential diagnosis. Though for the ICU setting especially, it's important to understand what complications to monitor for and then how to emergently treat them if and when they occur. And those are, again, raised intracranial pressure, strokes, and seizures. So the empiric treatment of meningoencephalitis, as mentioned earlier, in terms of your age group and common infections, bacterial and viral that exist, there are clear antibiotics and antivirals that you can use. To note that pneumococcal or Streptococcus pneumoniae is one of the most common community-acquired entities, and ceftriaxone has traditionally been a great drug, but one needs to make sure that you're giving appropriate dosing that can penetrate the CSF. And I think Dr. Flick spoke earlier in your series about different pharmacokinetics of drugs for different diseases in the ICU. The other element about Streptococcus is that unfortunately there's been a lot of global resistance to it. So patients who have very severe disease, it's often good to add vancomycin as well. For patients who are elderly or immunocompromised, thinking of listeria, the classic association is with cheese. Is important, Neisseria, as we discussed, and then any healthcare associated coverage for patients with risk factors to, say, Pseudomonas or other entities. However, this is a very small list compared to the entities that do exist, and patients can have parasitic diseases, tetanus. It really depends on the presentation and manifestations and your diagnostic workup. Which brings us to another controversial element in the treatment of meningoencephalitis. So who do you give steroids to? This tends to be controversial. In medicine, for anything, if you don't know the answer and you say it depends, you will be correct. And this is one of them. So it depends on what the diagnosis is, which gets back to the initial workup we were doing. In patients with TB, as you may know, steroids are very helpful, and often you may give prolonged courses of them. However, in patients with malaria, they can actually make things a lot worse. In terms of bacterial meningitis, the controversy arises because many animal studies that have been done show that steroids are great in the fact that they reduce inflammation in the meninges area. However, this then decreases the drug's ability to penetrate and then reach effective levels to do their action. So one element is that you may be able to alter your drug doses depending on that. But that's one of the reasons why practice has moved towards attempting to give steroids before antibiotics are administered if you are concerned for a community-acquired meningitis. And so giving dexamethasone before or with the antibiotics, and just a short course, enough to decrease inflammation to avoid long-term sequelae, has been found to be helpful. This Cochrane review actually, though, found a reduction in mortality, but the confidence intervals cross 1, so it wasn't statistically significant. So that's another element of uncertainty. But for reducing hearing loss, it has definitively been helpful. And this is just to reiterate, the blood-brain barrier creates a very sacred space around the brain, protecting our brain from the elements. But this often breaks down in the setting of infection, but still is harder to reach than most sites in our bodies. So a lot of antibiotics that we use, like aminoglycosides, fluoroquinolones, macrolides, these do not penetrate the meninges, and so are not helpful in these conditions. And then, as mentioned, you want to give higher doses of some of the medicines in order to also cross the blood-brain barrier. So back to our case. So our gentleman is still in your emergency department, and he received antibiotics. However, despite that, your nurse has called you and he's somnolent and he's grunting, and you assessed his GCS and it's 8. Would anyone want to raise their hand and let us know what you would do in this case? Oh, someone is saying they're not able to hear. I don't know, Amanda.
We can hear you fine. I think you can disregard that comment.
All right, so first things first, the differentials and everything will do their thing, but your airway breathing circulation is important, and it sounds like this patient is losing his protective airway reflexes, and potentially his neurological condition is progressing. So you want to stabilize your patient and intubate them emergently for the risk of airway protection. And this brings us to the ICU now. And so while your patient is in the ICU, in terms of your plan, things that you want to do are really good supportive care. So doing all the things that we do for our patients in the ICU in a multi-modal, multi-systemic fashion, making sure all your electrolytes are good, all your vital signs are stable, but specifically with this neurological condition, ensuring that you're doing frequent neurological checks. And often, if there is a risk, having some sort of neurosurgical plan or support if something were to worsen, especially in terms of the conditions we were mentioning that can evolve. And so projecting and trying to understand what complications may occur in a patient's trajectory. And diagnostics such as head CT and EEG can help you triage these conditions, which we'll talk about. And then just going forward, this was a talk that you had earlier in the session where one of my colleagues talked about neuromonitoring techniques. And this is another place where all of these tools can be put to good use in being able to determine your patient's course and when to intervene. But in order to know when to intervene, one needs to have a good neurological exam. And this often tends to be challenging in the ICU. Patients may have a lot of confounders, such as having delirium due to infections or other causes, such as being in the ICU itself, or sedation that we are giving. And both of these make our neurological assessment very difficult. However, there are lovely reviews talking about how to do a good neurological exam on an intubated and sedated patient. And firstly, if the patient is stable and able, doing a awakening trial to assess is often the most helpful. But if they're not able to, one can still get a fairly good assessment of one's neurological function. So overall, when you walk into the room or check for any plane reflexes, understanding if there's any focality. Many times my nurses will tell me that my patient is not moving their right arm too much, and then we'll do a further assessment. looking at ocular reflexes, deviation of your ocular movements to any gaze preference. Often it can be a subtle sign of seizures. Often and times these patients can actually have subclinical seizures, which may not manifest in the true movement and general tonic-clonic movement form that we tend to know of. And you may see just something called gibbous, which is just small pupillary dilation and constriction. Additionally, doing ocular ultrasounds, which you may have learned about, can give you an assessment of the intracranial pressures. And then more brainstem reflexes, which you can assess by if you have a suction catheter to put through the endotracheal tube and see if a cough reflex or a protective cough reflex is elicited. And then general reflexes. All of these can be helpful to ascertain a patient's neurostatus, but more important than the same at any one point of time is a continuous monitoring and frequent rechecking to see if there's any change. And speaking of change, for our patient, 4 hours later, your nurse calls you again because in her next neurological exam, this is what she sees in his pupils. So this is an unfortunate emergent condition where he looks like he is developing herniation. Herniation in patients with meningitis encephalitis is often diagnosed at the end of life in autopsies, but can occur in a wide population. And so emergent management, ensuring the patient's head of the bed is at 30 degrees, temporizing measures that you can use are increasing the respiratory rate on your ventilators, and then giving hypertonic saline. Hypertonic saline has had better outcomes than mannitol and other supportive elements. However, these are all temporizing alone, and so neurosurgical intervention and release of the pressure is one of the key interventions. Oftentimes we will call our neurosurgical colleagues who will place these devices called external ventricular drains, and what these are basically a tubing and needle that goes into your ventricle space, as you see on the right, and then filters out, has a manometer that takes out any excess CSF pressure and fluid above a certain threshold. And this is based on the Monroe-Kelly doctrine, which you may have learned about, which it basically is that, as one can imagine, our brain and our skull is a closed space and does not have capacitance to take in more volume. And so the perfusion pressure, or the amount of pressure that our blood vessels and our brain can tolerate, it is a close relationship with our mean arterial pressure, but also the intracranial pressure. And the ICP, or the intracranial pressure, can often go up in the case of infections. And this is why we worry about these entities. Sometimes burr holes may be a temporizing measure before more definitive access is available. And there are some studies where there's practice of trying to do serial LPs, but there is a higher risk of herniation, and so that would be needed to be done with caution, and again taking an appropriate amount of CSF at a time. In terms of seizures as a complication, as mentioned, this, because of the non-convulsive seizures, often there's a need for more continuous EEG. So if you have a patient who otherwise you've given good treatment for and is not improving or waking up or able to wean from the ventilator, then this may be a consideration. And patients who are immunocompromised or have had alcohol use disorder are often at higher risk for seizures. And these are often more common than we think of. However, despite all of these thorough elements of empiric treatment and diagnostics that you may do the best for your patients. And even then, your patients may not improve. And in fact, in studies, they've found that for patients who have viral entities based on the pattern of their CSF fluid, almost 50% of patients were not able to come up with a definitive diagnosis. And that's where then exclusion of infection and thinking of other alternatives, like autoimmune conditions or drug reactions or malignancies at times can be in your differential. But there are these new panels of diagnostic tests that have that are revolutionizing the field in some ways. And one is the multiplex panel on the right, and then the left is a new metagenomic sequencing panels. The latter have not fully translated to practice, however, are a emerging element where basically they test for any type of DNA or RNA substances and are able to give a unbiased sequence of any entities that may be present in the brain. And this becomes especially relevant in our current changing world globally, where we're seeing many pandemics, but new zoonoses, new diagnoses, and emerging infections through various parts of the world. Here in the US, we're seeing changing patterns of the West Nile virus. In India, there are outbreaks of a Nipah virus and Japanese encephalitis viruses. And so just to note that while we may not work on the public health side, we are the front line of seeing the downstream effects, and our role can be to trigger public health systems to be able to help with both diagnostics and epidemic assessment in hopes to mitigate further pandemics. And so just to close, while we see, again, a lot of the downstream effects of our systems working in different ways, it's vaccinations and preventions that often does save lives. And so a lot of the meningitic and encephalitic conditions are vaccine preventable. And so vaccination where possible for these elements, especially based on your epidemiology, are invaluable. And of course, related to these complications, one can imagine various sequelae, and you had a lovely session on post-intensive care syndrome and rehab, which become very relevant for patients, but also all the inflammation can cause obstruction of the CSF flow and lead to hydrocephalus, leading patients to need ventricular shunts or other elements to decrease that pressure. And so in summary, this is an emergency. Intervene with medications and your diagnostic workup, and then continue to monitor for potential complications and vaccinate your patients where you can. And thank you all. Thank you for your time. And I'm open for questions or any other discussion. And I'd love to hear also your experience with patients that you've had perhaps challenges managing.